Good morning, everyone. Today we are going to discuss about adult congenital heart disease posted for non-cardiac surgery. What are the anesthesia consideration? We did a case of Ebstein anomaly. This was an adult patient posted for TB annealing. Dr. Vijay Donde and myself, we did this case with the help of cardiologist, intensivist, and orthopedic surgeon. Nowadays, with improved surgical, anesthetic, and cardiological management, 85 to 90% of children affected by congenital heart disease survive into adulthood. As a consequence, adults with congenital heart disease constitute a fast-growing population globally. I could not find out the estimates of adult congenital heart disease population in India, but in United States of America, estimates suggest that more adults than children are living with congenital heart disease in United States. Many of these patients will require additional palliative or curative cardiac surgery and non-cardiac surgery at some time during adulthood. Adults with congenital heart disease demonstrate specific and complex anatomy and physiology. Perioperative morbidity and mortality are increased in adults with repaired or palliated or uncorrected undiagnosed congenital heart diseases. Few guidelines are available to direct the management of these challenging patients. Task Force of American College of Cardiology recommended that adult patients with moderate to severe congenital heart diseases undergoing non-cardiac surgery should be referred to an adult congenital heart disease center to obtain appropriate consultation with expert cardiologist and anesthesiologist. In my knowledge, there are no such centers available in India. With this background, let's discuss the case which we did and lessons we learned from this case. Although Ebstein anomaly occurs in only 0.3 to 0.7% of total congenital heart diseases, it is the most common congenital malformation of tricuspid wall. The incidence is approximately 1 in 10,000 live births. It was first described by Ebstein in 1886 from autopsy finding. It is characterized by malformed tricuspid and right ventricle, and interatrial shunt is almost invariably present, as over 1/3 will have an ASD and most of the remainder patients will have PFO. Here you can see this is the normal tricuspid wall, but in Ebstein anomaly, this atrioventricular junction is shifted distally, and therefore the most of the RV is atrialized and the functional right ventricle becomes small. Along with there is PFO or ASD with right to left shunt causing cyanosis. The tricuspid regurgitation of Ebstein anomaly and the degree of downward displacement of the tricuspid wall variably impair adequate development of the heart. Significant tricuspid regurgitation places a volume load on the right ventricle that results largely in dilated right ventricle that impairs the left ventricular function. This severe tricuspid regurgitation produces a massively ballooned right atrium. As pulmonary vascular resistance decreases and stabilizes to near adult values, forward flow in the neonatal right heart can cause Ebstein anomaly signs to improve. A cyanotic neonate with an unrestricted ASD may eventually become acyanotic with acceptable cardiac output. However, an infant with restrictive ASD can have a low cardiac output due to LV impairment from malposition of the interventricular septum with paradoxical movement. Here in this figure, you can see the Carpentier classification of the Ebstein anomaly. In the mild variety, the functional right ventricle is a good amount. Therefore, there is adequate cardiac output. But in the fourth category, the most of the right ventricle is atrialized and leaving very small functional right ventricle. And these patients will have very high cyanosis and very high rate of complications. The distortion of atrial and ventricular chambers with Ebstein anomaly is associated with arrhythmias that can further impair function and can be life-threatening. As many as 25 to 30% of individuals will have atrial flutter, atrial fibrillation, paroxysmal supraventricular tachycardia. Following electrophysiological abnormalities are seen in Ebstein anomaly: PR interval prolongation, RBBB, WPW syndrome, SVT, atrial fibrillation, and deep Q waves in V1 to V4 and inferior leads. Now, coming to the patient history, this was a 45 years male. He was admitted with history of road traffic accident. He was having right tibia fracture. Along with that, there was a right 10th rib fracture with lung contusion. There was no significant past history. His pulse rate was 100, regular, BP was 180, 100, and saturation was on lower side. On room air, it was only 65 to 70%, and it improved with nasal oxygen to 80 to 85%. Initially, it was thought that the low saturation is due to rib fracture and the lung contusion. The lab investigation showed very high hemoglobin, though he was not a smoker. Liver enzymes HGOT, HGPT were raised, and as expected, it showed a low PO2 on the ABG with low arterial saturation. Along with that, his INR was high, that is 1.61. His ECG showed a normal sinus rhythm with bradycardia. There is increased PR interval, increased QT interval, and the deep Q waves in the inferior leads. Now, his echo findings were very interesting. He was having dilated right atrium and the right ventricle. 50% of his right ventricle was atrialized with severe tricuspid regurgitation, and there was an ASD with right to left shunt. This confirmed the diagnosis of Ebstein anomaly. Now, with this diagnosis of Ebstein anomaly, we can correlate low saturation and low PaO2 on ABG with low pulmonary blood flow, right to left shunt leading to high hemoglobin with cyanosis, raised liver enzymes with free tricuspid regurgitation leads to raised INR with coagulopathy associated with the cyanotic congenital heart disease. His CT chest revealed patchy pneumonitis with right upper and middle lobe involvement. He was having right side pleural effusion, and there was 10th rib fracture on the right side. After doing the PSE, we clearly explained to relatives about the risk involving anesthesia, though the surgery per se was not that risky. This patient was posted for nailing of the tibia, and the surgeon who was going to do that surgery was very quick. So we expected that this surgery will not last longer than 25 to 30 minutes. Now, the main question was what anesthesia we will offer to such patient. General anesthesia in a cyanotic congenital heart disease patient who is also having pneumonitis, rib fracture, and pleural effusion with raised liver enzymes was too much, and it was risky, what we consider, because surgery is not going to last for more than half hour. But choosing to give spinal with raised INR was also not easy. So I advise injection vitamin K and repeat INR after 24 hours. In this 2004 British Journal of Anaesthesia article by Dr. Lovell, he mentioned that the benefits of regional anesthesia alone or in combination with general anesthesia need to be weighed on an individual basis. The benefits from good post-operative analgesia and avoidance of activation of the sympathetic nervous system with consequent catecholamine release need to be weighed against the effects of reduction in systemic vascular resistance. The circulatory effects of IV induction agents are well known. All of the commonly used IV induction agents can be used safely. The rate and the dose administered are more important than the actual drug use. So you can either choose regional anesthesia or general anesthesia depending on the patient's congenital heart disease, severity and complexity of the heart disease, as well as the surgical complexity. So we considered that this surgery is not going to be very complex or long duration surgery. The patients with adult congenital heart disease have an increased risk of developing infective endocarditis. Antibiotic prophylaxis continues to be recommended for patients with high-risk characteristics. And these patients include patients with prosthetic valves, patients within 6 months of placement of prosthetic material, patients with residual intracardiac shunts, and patients with uncorrected cyanotic heart disease. This patient received infective endocarditis prophylaxis before surgery. Now, this small clip shows baseline parameters of the patient when we took him inside the OT. This red colored trace is of SpO2 and it was around 72 only. One can clearly note that the saturation is low on room air and he was having right tibia fracture. After discussion with relatives, surgeons, cardiologists, and among our team members, we choose to give spinal with inotropic support for perioperative period. Even after 3 doses of injection vitamin K, his INR was still high, but fortunately, single prick with 25 gauge spinal needle was required for spinal with bupivacaine 3 ml without any additives. Now, after giving spinal, in this video, you can see what are the post-spinal events. The series of events occurred. First event was expected and we were ready for that. You guessed it right. There was hypotension which responded to mefentermine single dose and non-adrenaline infusion, but patient became restless. Here you can see sinus tachycardia with a heart rate of 115. Initially, we started with a heart rate of around 65 to 70. There is hypertension and saturation increase with Hudson mask with reservoir bag. Next unexpected thing was convulsions, which we managed with midazolam 3 milligram IV bolus and bag mask ventilation. Here you can see the patient had atrial fibrillation with fall in the blood pressure and saturation. We added dopamine infusion to support the failing right ventricle, gave 500 ml of ringer lactate bolus to increase the preload, which was required for patients with severe tricuspid regurgitation. Saturation improved in some time with very high FiO2. Fortunately, patient responded well to amiodarone bolus and inotropes. He regained sinus rhythm with good blood pressure. Surgery was uneventful in short duration. Introp ABG showed acidosis, which was corrected and patient shifted to ICU with stable hemodynamics. He was obeying command after surgery. Here you can see the rhythm, though there is tachycardia, it was reverted to sinus. Blood pressure is on higher size, 180 by 100, and saturation improved from almost 25-30 to 91%. Post-op day 1, we did MRI brain. Patient was fully conscious, oriented, and inotropes were tapered off. His creatinine was raised, which settled in next 5 days. His MRI brain showed he was having frontal and occipital acute infarcts. There were multiple microhemorrhages indicating diffuse axonal injury. This article, which was published in 2010, clearly mentions that cerebrovascular accidents is a major cause of morbidity in congenital heart disease patients, and the risk of CVA is tenfold higher in cyanotic patients. Extracardiac manifestations of adult congenital heart disease. This article published by Dr. Stephen in 2016 mentions strikingly high rates of stroke in adult congenital heart disease patients. Among 30,000 adult congenital heart disease patients, 9% of men and 7% of women suffered stroke before age 65, with an incidence of ischemic and hemorrhagic stroke 12 and 6-fold higher than the general population. So definitely the risk of stroke is very high. Ischemic stroke was associated with heart failure, diabetes, and recent myocardial infarction. The congenital heart disease lesion predisposing to cyanosis, which was the case in our patient, and left-sided congenital heart disease lesions had the highest associated stroke rate. So our patient was clearly in the high-risk category for stroke. This patient not only had ischemic cerebral infarcts, but also had multiple microhemorrhages in the brain. And this article, published in International Journal of Cardiology in 2014, helps to explain the cause of very high INR in adult congenital heart disease patients. Author demonstrated that the acquired von Willebrand syndrome in patients with various congenital cardiac defects, but the highest prevalence occurred in the patients with complex congenital heart diseases and the Eisenmenger syndrome. Therefore, they suggested preoperative screening for acquired von Willebrand syndrome in all the patients with congenital heart diseases, particularly in the patients with congenital heart disease of greater complexity. So this patient was having greater complexity, but we did not screen patient for coagulopathies, and I think it was necessary as INR was high even after 3 doses of injection vitamin K. This article, published in Anaesthesiology Journal in 2014, studied factors contributing to the adverse perioperative events in adults with congenital heart diseases. They found 21 cases. Out of that, 11, that is almost 50%, involved cardiac surgeries and another 10 non-cardiac procedures. The most common factors contributing to the adverse event in cardiac cases were surgical technique and intraoperative anesthetic care, whereas in non-cardiac cases, the post-operative monitoring contributed 50% and the preoperative assessment or the optimization contributed 40% for the causes of adverse perioperative outcomes. In light of these facts, we should have done better monitoring perioperatively with invasive blood pressure, that is arterial line, and CVP, which we didn't do in this case. Heart failure is the leading cause of death for adults with congenital heart diseases, which makes invasive monitoring more valuable. And I regret for not doing that in this particular patient with Ebstein anomaly who was posted for tibia fracture. In this paper, authors compared the 3 most common and relevant risk models. The first is the mortality score constructed in 2009 by the European Association of Cardiothoracic Surgery and the Society of Thoracic Surgeons, that is the STAT mortality score. The second score is adult congenital heart surgery mortality score, which was published in 2015 by Fuller. The third model, that is adult congenital heart disease anatomic and physiological classification, was recently introduced as part of the guidelines of the American Heart Association and American College of Cardiology for management of adult congenital heart disease patient. It combines anatomic complexity with physiological clinical status of the patient. Anatomy is described as simple, that is grade 1, moderate grade 2, and severe complexity with grade 3. Whereas physiology is listed in 4 categories of increasing severity from A, B, C, and D. Such a mortality score is not available for non-cardiac surgery patients with adult with congenital heart diseases. So can we use this adult congenital heart disease anatomic physiological score for non-cardiac surgery in congenital heart disease patient? This needs to be explored. And I think if such score is available, then we can more accurately predict the perioperative mortality in patients with congenital heart diseases. So fortunately, this patient was successfully discharged home on 10th post-operative day, and his first follow-up is due in next few days. Important take-home messages from this case are: the preoperative optimization will play major role in perioperative good outcome. So preoperative coagulopathy testing is required in adult congenital heart diseases patient. Extra cardiac manifestations of adult congenital heart diseases need careful identification and management. So these patients are of high risk of getting stroke perioperatively. So we need to expect that and manage accordingly. Monitoring should include standard parameters and invasive blood pressure and CVP. Now, regarding these standard parameters, we should remember that the SpO2 monitoring underestimates the cardiac output, that is systemic cardiac output, in left to right shunt, while EtCO2 underestimates the PaCO2, that is EtCO2 will underestimate PaCO2 in patients those are having right to left shunt. Therefore, frequent ABG should be monitored to exactly know whether there is acidosis due to low systemic cardiac output or there is hypercapnia, which will lead to the high pulmonary vascular resistance, and it will further decrease the right ventricular cardiac output. Multidisciplinary team is necessary for successful outcome. Poorly functioning right ventricles are dependent upon high filling pressure to maintain adequate cardiac output. So in our case, we should remember that we should maintain a very high CVP, and for that, we need to monitor CVP. Choice of anesthesia depends on severity of Ebstein anomaly and complexity of the non-cardiac surgery. So depending on not only the severity of the disease, but you should also consider what type of surgery we are going to perform and what type of anesthesia we need for this patient. As per the European guidelines, we need a multidisciplinary collaborative care team of various specialties to manage the adult congenital heart disease patients. And these specialties include transplant surgery, congenital surgery, interventional cardiology, specialist in managing pulmonary hypertension, then palliative care specialists, psychiatrists, and the social workers, hepatology, electrophysiology, then intensive care, anesthesiologist, adult congenital and pediatric cardiologist, adult heart failure specialist. So such type of adult congenital heart diseases centers are available in Europe. But we manage this case with 2 anesthesiologists, cardiologists, intensivists, and a orthopedic surgeon. In low resource country like ours, unity is the strength. When there is teamwork and collaboration, wonderful things can be achieved. So I thank everyone for your patient listening. These are the American Heart Association and European Society guidelines for the management of adult congenital heart disease patients. We need such guidelines for managing adult congenital heart disease patients who are posted for non-cardiac surgery. We all should contribute by sharing our experiences of such cases. Thank you.